The purpose of this video is to explore a practical approach to improving the safety of rapid sequence induction when using total intravenous anesthesia. Although this presentation is primarily aimed at anesthesia trainees who are developing confidence with TIVA and target-controlled infusion, I hope it will also be of interest to experienced anesthetists looking to refine their practice. Rapid sequence induction remains one of the most time-critical procedures in anesthesia. While TIVA offers many recognized advantages, achieving the speed of induction expected during RSI can be challenging when using standard TCI techniques. In this presentation, we'll examine why those challenges exist, review how current TCI systems behave during induction, and introduce a simple technique that allows a rapid induction dose of propofol to be delivered while ensuring that the TCI pump incorporates that dose into its pharmacokinetic model. The objective is straightforward: to combine the speed of conventional RSI with the pharmacokinetic advantages of TCI while reducing the risk of inadvertent repeat loading doses and the hemodynamic consequences that may follow. Interest in the use of TIVA for rapid sequence induction increased considerably following the publication of the Pamela Marking Prevention of Future Deaths report. The report prompted an important discussion within the UK anesthetic community about whether current TIVA techniques are able to meet the fundamental objectives of rapid sequence induction. Among the concerns raised by the coroner was the observation that there was a lack of updated national guidelines to support the use of TIVA for RSI. The report also highlighted another important consideration: TIVA being known to provide a slower onset of anesthesia, and approximately 50% of all anesthetic-related deaths are due to aspiration, NAP4. These comments are significant because the defining principle of rapid sequence induction is the rapid achievement of unconsciousness and neuromuscular blockade, thereby minimizing the period during which the airway remains unprotected. If TIVA cannot reliably provide an induction that is comparable in speed to conventional intravenous bolus induction, it is reasonable to question whether current TCI techniques are ideally suited to RSI. The purpose of this presentation is not to debate whether TIVA should or should not be used for RSI. Rather, it is to explore how TIVA can be performed in a way that preserves the speed expected of a rapid sequence induction while maintaining the pharmacokinetic advantages of target-controlled infusion. In their response to the Prevention of Future Deaths report, Surrey and Sussex NHS explained that clinicians within the trust routinely perform RSI using a modified TIVA technique. They stated, "At the trust, if a clinician is using TIVA for RSI, they always use a modified TIVA technique, which involves a predetermined dose of propofol as the induction agent, administered as a bolus, and a predetermined dose of muscle relaxant, administered as a bolus. This allows for rapid anesthesia." This is an entirely logical approach. The induction dose of propofol is administered rapidly, followed immediately by neuromuscular blockade, while maintenance of anesthesia is then continued using TIVA. In practice, this can be achieved in one of two ways. The first is by using the pump's manual bolus function, where available. The second is by administering the induction dose from a separate syringe before commencing TCI. I'll return to the manual bolus function later, as it behaves rather differently. For the moment, let's consider the second approach. When propofol is administered from a separate syringe, the TCI pump has no knowledge that the induction dose has already been given. From the perspective of the pharmacokinetic model, the patient has received no propofol at all. Consequently, when TCI is started, the pump calculates and delivers its own loading dose in order to achieve the selected target concentration. In effect, the patient receives two induction doses, the clinician's bolus, followed by the pump's calculated loading dose. Depending on the clinical situation, this may result in unnecessary propofol administration, increasing the likelihood of hypotension and other hemodynamic complications, particularly in vulnerable patients. Before considering any alternative technique, it's worth looking at the physical limitations of the infusion pump itself. Our B bronze space pumps have a maximum infusion rate of 1,800 milliliter per hour, equivalent to approximately 0.5 milliliters per second. For a typical induction dose of 160 milligrams of propofol or 16 milliliters of 1% propofol, the pump therefore requires approximately 32 seconds to deliver the entire dose, assuming it can maintain its maximum flow rate throughout. In clinical practice, however, this maximum rate is not always achieved. As line pressure increases, the pump may approach its pressure limit, triggering an occlusion alarm and temporarily interrupting drug delivery until the pressure is relieved. This inevitably prolongs the time taken to deliver the induction dose. The question, therefore, is not whether the pump can deliver the required dose. It clearly can. The more relevant question is whether a delivery time measured in tens of seconds is compatible with the principles of rapid sequence induction, where we would ideally like the full induction dose to be administered over just a few seconds. The limitation becomes even more apparent when we examine how a standard TCI induction is actually delivered. In this example, the pump is configured using the Eleveld with opioids model for an 80 kilogram, 170 centimeter, 50-year-old male. From a clinical perspective, we might decide that this patient requires an induction dose of 2 milligrams per kilogram of propofol, approximately 160 milligrams, before continuing anesthesia with a target concentration of 4 micrograms per milliliter. Notice, however, that the pump calculates a loading dose of 174 milligrams, slightly greater than the dose we intended to administer. More importantly, the equivalent of our planned induction dose, 160 milligrams, is not delivered until approximately 80 seconds after commencing TCI. If you look carefully at the infusion profile, you'll also notice that the delivery rate progressively slows after approximately 120 milligrams has been infused. This behavior is entirely expected. The TCI system is not designed to deliver propofol as rapidly as possible. Its objective is to achieve the selected target concentration while avoiding excessive overshoot of the pharmacokinetic model. For routine induction of anesthesia, this behavior is entirely appropriate. However, during rapid sequence induction, our priorities are rather different. Our aim is to deliver the full induction dose as quickly as possible while maintaining pharmacokinetic accuracy once anesthesia has been established. Having looked at how conventional TCI behaves during induction, we can now define what an ideal TIVA technique for rapid sequence induction should achieve. In reality, there are only two essential requirements. First, the predetermined induction dose of propofol should be delivered as rapidly as possible. The dose itself should be calculated in advance according to the patient's weight and the clinical circumstances, but once the decision to induce has been made, it should ideally be administered over only a few seconds, just as it would be during a conventional RSI. Second, the TCI pump must recognize that this induction dose has already been administered. The pharmacokinetic model should incorporate the dose into its calculations from the very beginning, so that when maintenance TCI begins, the pump does not deliver a second loading dose. If both of these conditions can be met, we retain the speed of a conventional intravenous induction while preserving the pharmacokinetic advantages of target-controlled infusion. The remainder of this presentation demonstrates a simple technique that achieves exactly that. Let's now look at the practical setup. For this demonstration, I'm using a standard TIVA circuit with propofol and remifentanil. However, the same principle can be used with propofol alone or with alternative extension tubing such as PCA lines. Only 3 additional components are required: an extension line, a 3-way stopcock, and a 20 milliliter syringe. These simple additions allow the induction dose to be prepared by the TCI pump before induction, while remaining fully incorporated within the pharmacokinetic model. This slide illustrates the completed setup. The most important component is the 3-way stopcock. At this stage, it should be closed towards the patient. With the stopcock in this position, propofol delivered by the TCI pump is diverted into the 20 milliliter syringe rather than to the patient. The syringe therefore acts as a temporary reservoir, allowing the predetermined induction dose to accumulate before induction begins. The target volume should be calculated in advance according to the patient's weight and the clinical situation. Once the system has been assembled, the next step is simply to allow the TCI pump to fill the reservoir syringe with the predetermined induction dose. During this time, no propofol is being delivered to the patient. This provides an opportunity to continue pre-oxygenation, complete the final equipment and airway checks, and administer any additional medications such as fentanyl if appropriate for the clinical situation. Once the planned induction dose has accumulated within the reservoir syringe, perform your final pre-induction pause. The three-way stopcock is then rotated towards the patient, and the system is immediately ready for induction. The induction itself is now performed exactly as it would be during a conventional rapid sequence induction. Using the reservoir syringe, administer the entire induction dose of propofol at your usual rate. The speed of injection is now determined entirely by the clinician rather than by the infusion pump. Immediately afterwards, administer the neuromuscular blocking agent according to your standard RSI practice. From this point onwards, airway management proceeds in exactly the same way as during a conventional intravenous induction. Once induction dose of propofol has been administered, the three-way stopcock is simply returned to its normal position, allowing propofol to flow directly from the pump to the patient. From this point onwards, the system functions as a standard TCI circuit. The reservoir syringe is no longer required and can be removed during the next routine propofol syringe change, allowing the circuit to return to its usual configuration. Before demonstrating the Reservoir TCI technique in real time, it's worth taking a moment to understand how a standard TCI pump behaves immediately after induction. Once the initial loading dose has been delivered, the pump does not immediately continue the infusion. Instead, it enters a brief pause while the pharmacokinetic model predicts equilibration between the plasma and the effect site. During this period, little or no propofol is infused. Only once the predicted concentrations begin to fall does the pump recommence the maintenance infusion required to sustain the selected target concentration. This behavior is entirely normal and reflects the way TCI systems are designed to operate. Understanding this sequence is important because it explains why the Reservoir TCI technique can deliver a rapid induction dose without immediately triggering additional propofol administration. Some B-Bron pumps retain the manual bolus function. Where this feature is available, it provides a useful illustration of how the TCI model responds to externally administered propofol. When a manual bolus is delivered, the pump does not simply infuse the selected volume. It also incorporates that dose into its pharmacokinetic calculations. This can be seen immediately on the display, where both the predicted plasma concentration and the predicted effect site concentration increase in response to the bolus. Because the model recognizes that propofol has already been administered, the pump does not calculate or deliver a further loading dose, even if the selected target concentration is subsequently changed. Instead, it waits until the predicted concentration falls sufficiently before recommencing the maintenance infusion. The cumulative propofol dose displayed by the pump clearly demonstrates this behavior. The same principle applies during maintenance anesthesia. If clinical circumstances require a rapid increase in anesthetic depth, a manual bolus can be administered without disrupting the pharmacokinetic model. Immediately after the bolus, the predicted plasma and effect site concentrations increase, reflecting the additional propofol that has been given. At the same time, the maintenance infusion is temporarily reduced or paused because the pump recognizes that the target concentration has already been achieved. If a higher TCI target is subsequently selected, for example, increasing the target from 4 to 5 micrograms per milliliter, the pump still does not administer another loading dose. Instead, it resumes infusion only when the predicted concentration approaches the new target. In other words, the manual bolus becomes part of the pharmacokinetic model rather than existing outside it. This principle is fundamental to understanding why the reservoir TCI technique works. Let's now see how the reservoir TCI technique works in practice. This demonstration uses one of our newer B-bronze space pumps, where the manual bolus function has been disabled. The pump is configured using the Eleveld with opioids model for an 80 kilogram, 170 centimeter, 50-year-old male. Before induction, we first decide on the dose we would normally administer during a conventional rapid sequence induction. In this example, that dose is 2 milligrams per kilogram of propofol, giving a total induction dose of 160 milligrams. Following induction, anesthesia will be maintained using a TCI target concentration of 4 micrograms per milliliter. The first step is to program the desired TCI target. At this stage, it's important to confirm that the pump's calculated loading dose is at least equal to the induction dose you intend to administer. Occasionally, this may require selecting a slightly higher initial target concentration. If necessary, the target can be reduced after induction has been completed. TCI is then started in the usual way. However, because the three-way stopcock is closed towards the patient, the propofol is delivered into the reservoir syringe rather than intravenously. While the reservoir syringe is filling, pre-oxygenation and the final pre-induction checks continue as normal. Once the planned induction dose has accumulated, the three-way stopcock is turned towards the patient. The induction dose is then administered rapidly from the reservoir syringe, exactly as it would be using a conventional syringe of propofol. The neuromuscular blocking agent is administered immediately afterwards, and rapid sequence induction proceeds according to standard practice. Now watch what happens next. Although the induction dose has been delivered over only a few seconds, the pump does not attempt to administer another loading dose. Instead, it behaves exactly as a TCI system should. The pharmacokinetic model recognizes that the induction dose has already been delivered, enters its normal equilibration phase, and only recommences maintenance infusion when the predicted concentrations begin to fall. The result is a rapid induction comparable to conventional RSI, while preserving the pharmacokinetic integrity of the TCI model and avoiding an unnecessary repeat loading dose. In essence, the reservoir TCI technique combines the speed of conventional intravenous induction with the advantages of target-controlled infusion.